Picture this. You're 71 years old. You feel great. You're sleeping well, your energy is good, you're still doing the things you love. You go to your doctor for a routine visit. Nothing wrong, nothing urgent, just a checkup. Your doctor glances at your chart and says, "Your blood pressure is reading a little high today. Let's start you on something just to protect you." You say, "Okay," because you trust your doctor, because that's what responsible people do. 7 weeks later, you're dizzy every time you stand up. You've fallen twice in your own kitchen. You've stopped driving because something feels off. You mention it at your next appointment, and your doctor adds another prescription, this one for the dizziness. And nobody in that room stops to ask the one question that would have changed everything. Was the first medication the problem all along? That story is not unusual. I hear versions of it more often than I should, and the data behind it deserves an honest conversation, the kind that rarely happens in a 15-minute appointment. My name is Dr. Deborah William. I've spent years studying what the medical research actually says about aging, medications, and the gap between what's prescribed and what's proven. And today, I want to walk you through 5 medications routinely given to adults over 65. Medications that carry risks most people are never told about in plain language. This is not about fear. This is about being informed. Because the most dangerous place to be in medicine is compliant without understanding. Stay with me through all 5. Number 3 genuinely surprises most people, even those who've been in healthcare for years. And number 5, that one has changed how people I know talk to their doctors forever. Before we get into it, drop your name and where you're watching from in the comments. I genuinely read them. It helps me know who I'm here for. You're 67 years old and you're on 4 medications, maybe 5. Each one was prescribed at a different appointment by a doctor who was focused on one specific thing. Nobody ever looked at all of them together in the same room at the same time. That's not carelessness, that's just how the system works. But here's what the system doesn't tell you. After 65, your body processes medication differently than it did a decade ago, and nobody updated the dosing conversation to account for that. There's something I call the medication math problem. It works like this. When you're 45, your liver processes drugs efficiently. Your kidneys clear them quickly. Your brain has significant reserve. So when a medication causes a side effect, your body catches it and compensates. After 65, that math changes in 3 specific ways. First, your kidneys slow down. Drugs that used to clear your system in hours now linger for days. Standard doses can quietly become overdoses, not because the prescription changed, but because your body did. Second, you're likely on more than one medication. Each one was tested in isolation. Almost none were tested in combination with the others you're taking. The interactions are largely uncharted territory. Third, medication side effects in older adults almost always look like something else entirely. Confusion looks like early dementia. Dizziness looks like an inner ear problem. Fatigue looks like depression. Falls look like clumsiness. So instead of stopping the drug that caused the problem, a new drug gets added for the symptom it created. Doctors call this a prescribing cascade. Once you're in one, it's very hard to find your way out. Keep that in your mind as we go through each one. Medication 1. Sleep medications, benzodiazepines, and Z-drugs. You're 73 years old and you haven't slept properly in 6 weeks. Your spouse just had surgery, you're worried, you're up at 3 a.m., and you're exhausted in a way that's starting to affect everything. You go to your doctor and you explain this. Your doctor listens and says, "Let's get you something to help you sleep while things settle down." That feels reasonable. That feels like relief. What your doctor may not tell you is that the sleep medication being prescribed, a Z-drug, the kind millions of older adults take regularly, carries warnings specifically for people your age that never make it into that conversation. These drugs slow your central nervous system. In older adults, that means impaired balance, cognitive fog, and a fall risk that compounds every night you take them. The American Geriatric Society's Beers criteria, the gold standard list of medications inappropriate for older adults, explicitly flags these drugs as high risk for anyone over 65. A study in the BMJ found that older adults on benzodiazepines had a 50% increased risk of a hip fracture. That's not a footnote. A hip fracture at 73 is one of the most common precursors to permanent loss of independence. Up to 30% of older adults who fracture a hip never return to their prior level of function. And here's what almost nobody mentions at the prescription counter. These medications are habit-forming. Stopping them after long-term use causes rebound insomnia that is often worse than what started the whole thing, which makes patients feel they need the drug, when in reality, their body has become dependent on it. What to ask instead? Request a referral for CBTI, Cognitive Behavioral Therapy for Insomnia. The American College of Physicians recommends it as first-line treatment over medication for chronic insomnia. A 2015 meta-analysis found it outperforms sleep drugs in long-term outcomes. No dependency, no fall risk, no morning fog. Medication 2, proton pump inhibitors, long-term acid suppression. You're 68 years old and you've been taking a small pill every morning for acid reflux for going on 3 years now. It works. You don't think about it much. It's just part of your morning routine, like coffee. Your doctor hasn't brought it up. You haven't brought it up. It's just there. What neither of you may have discussed is what that pill has been quietly doing to your body over 3 years of daily use. Proton pump inhibitors, PPIs, brand names like Prilosec, Nexium, Prevacid, block your stomach's ability to produce acid. Short-term, for a specific confirmed condition, they serve a real purpose. Long-term, without reassessment, they create a slow and largely invisible nutritional problem. Stomach acid is your body's first line of defense against bacteria you swallow. Suppress it chronically, and you increase your vulnerability to infections that are particularly serious in older adults. Studies estimate that between 25% and 70% of people currently on PPIs have no documented medical justification for continued use. The original condition resolved or was never properly confirmed, and that prescription just kept refilling. What to ask? What was the original reason I started this? Has that condition been confirmed? Is there a plan to reassess whether I still need it? A supervised taper, not a sudden stop, but that conversation needs to happen. If you're still here and finding this useful, drop it too in the comments. Medication 3. Anticholinergic drugs hidden in plain sight. You're 70 years old and you're pretty careful about your health. You read labels, you ask questions, you don't take anything you don't need. Every night before bed, you take a Benadryl because it helps you sleep. Every morning, you take an allergy pill, and your doctor recently started you on a bladder medication because of some urgency issues. You feel like you're managing things well. What you may not know is that all 3 of those medications belong to the same drug class, one that the research has directly linked to accelerated cognitive decline in older adults. They're called anticholinergics. They work by blocking a neurotransmitter called acetylcholine, which is critical for memory, coordination, and clear thinking. In a younger brain with abundant acetylcholine, blocking some of it causes mild drowsiness. In a brain over 65, where acetylcholine levels have already naturally declined with age, blocking it further can cause confusion, memory problems, increased fall risk, and over time, something far more serious. A landmark study published in JAMA Internal Medicine followed nearly 3,500 older adults over 10 years. People who used anticholinergic drugs for 3 or more years had a 54% higher risk of dementia. The researchers described it as a dose-response relationship: more exposure, more risk. And the reason this one stops people cold is that these drugs don't announce themselves. They're in antihistamines, bladder medications, certain antidepressants, muscle relaxants, and over-the-counter cold remedies. Someone can be diligently avoiding anything that sounds risky while unknowingly taking multiple anticholinergic drugs every single day. There is a tool called the Anticholinergic Cognitive Burden Scale. Ask your doctor or pharmacist to run your entire medication list, including over-the-counter drugs, against it. That single conversation could genuinely change where your health goes from here. Medication 4. Aggressively lowering blood pressure in older adults. You're 78 years old. Your blood pressure has been well managed for years. At your last appointment, your doctor mentions new guidelines recommend an even lower target. You adjust your medication, you're doing everything right. 2 months later, every time you get up from the couch, the room tilts. You've grabbed the door frame twice to stop yourself from going down. You chalk it up to getting older. But it's not age. It's your blood pressure being pushed below what your body actually needs. Here's the physiology that rarely gets explained in the appointment. As we age, our vessels stiffen. The brain, to compensate, actually requires a slightly higher pressure to maintain adequate blood flow and function properly. When blood pressure is pushed too low in older adults, the brain doesn't get enough perfusion. The result is dizziness on standing, orthostatic hypotension, along with confusion, fatigue, and falls. The SPRINT trial, which generated headlines for aggressively lowering blood pressure in older adults, also documented significantly higher rates of kidney injury, fainting, and serious falls in the intensive treatment group. That part of the story got less coverage. I'm not saying stop your blood pressure medication. Uncontrolled hypertension is genuinely dangerous. What I'm saying is that the target optimal for a 48-year-old is not automatically optimal for a 78-year-old, and treating it as if it is has caused real, documented harm. What to ask? What is my blood pressure target, and how was that number determined for someone my age specifically? What symptoms should tell us we've gone too low? Those 2 questions alone open a conversation most older patients have never been invited into. If you made it this far, drop a 4 in the comments. I see you. Medication 5. Statins started after 75 for primary prevention. You're 76 years old. You've never had a heart attack, never had a stent, never had a cardiac event of any kind. You go in for your annual physical, everything looks fine, and your new doctor says, "Given your age and cholesterol numbers, I'd like to start you on a statin, just to be preventive." That sounds responsible. That sounds like good medicine. Here's what the conversation often leaves out. For adults who've had a heart attack, a stroke, or established cardiovascular disease, statins have strong and consistent evidence of benefit. That evidence is real, and I'm not disputing it. But for adults over 75 who have never had a cardiac event, what's called primary prevention, the evidence base is far shakier than most patients are led to believe. The United States Preventive Services Task Force does not recommend initiating statins for primary prevention in adults 76 and older due to insufficient evidence of benefit in that population. What there is evidence for is this. Statins cause muscle pain and weakness, statin myopathy, in a meaningful subset of patients. In a 50-year-old, that's an inconvenient side effect. In a 76-year-old who is already navigating age-related muscle loss and fall risk, that muscle weakness carries consequences that are categorically different. You're 76 years old, and the thing you love most in your day is your evening walk. You've done it for 15 years. 3 months after starting the statin, your legs ache in a way that's making the walk feel like work instead of pleasure. You mention it at your next appointment, you're told it's probably just age. You stay on the medication another 6 months before someone finally connects the dots. That story happens every day. And the question that should be asked, but rarely is is whether the evidence supports starting this medication in you, specifically, at this stage of your life, when you've never had a cardiac event and the benefit for your age group has not been established. What to ask? Is this for primary prevention or because I have existing heart disease? What does the evidence show for my specific age group? And what symptoms would tell us the medication is affecting my muscles or my quality of life? Write these down before your next appointment. Put them in your phone. These 5 questions will change how you are treated in that room. Question 1. Is this medication on the Beers criteria list for older adults? And if so, what are the specific risks for someone my age? The Beers criteria is publicly available. Your doctor should know it. Asking signals you've done your homework and you expect a real answer. Question 2. How long have I been on this, and when did we last review whether I still need it? This is the question that uncovers prescribing cascades. Many people are on medications that were right for a temporary condition years ago and were never revisited. Question 3. What symptoms should tell me this medication is affecting me negatively? You deserve to know the side effect profile before you start, not after a fall or a cognitive change that took months to trace to a pill. Question 4. Is there a non-medication option with comparable evidence for my situation? For sleep, for acid reflux, for anxiety, for blood pressure management, non-drug options with strong evidence exist. They're just not the default because they take longer to explain than a prescription takes to write. Question 5. If we wanted to reduce my overall medication burden, where would you start and what would that process look like? This invites collaboration instead of confrontation. Most physicians, when asked this thoughtfully, will engage with it genuinely. You're 65, or 70, or 78 years old. You have things you love, walks you take, grandchildren who think you're invincible, a garden or a workshop or a Tuesday card game, or a chair by a window where the morning light comes in just right. That life, the specific texture of your daily life, is what medicine is supposed to protect. Not just your numbers, not just your chart, you. The system doesn't always have time to make that distinction. You do. That's why these questions matter. That's why knowing what's in your medicine cabinet matters. Not to become your own doctor, but to become an informed partner in decisions about your own body. Any physician worth their time will welcome these conversations. And if yours doesn't, that's important information. Subscribe if you want more of this. Honest, plain language conversations about health after 60. Every week, no fluff, no agenda. And if this reached you, help Dr. Deborah reach 1,000 subscribers, because this is exactly what 1,000 people need to hear. Leave a comment. Have you or someone you love experienced a side effect that took too long to be taken seriously? Your story might be the thing that sends someone else to ask the right question before their next appointment. Take care of yourselves.